you very much for inviting me to be here. It's always a pleasure to be here with you, with so many people that I know, patients, family members, and physicians, and this is an area that I'm very attached to in New York City, particularly in this area. I used to work here for 11 years. I was at Sloan Kettering, which is a couple of blocks from here. So I'm going to talk to you about a group of diseases that has taken the last 15 years of my research and as a physician and also as a translational researcher. So we saw the picture of this article this morning when Dr. Weir gave this wonderful introduction, historical introduction. This is Corsellis, the gentleman. And Corsellis was a pathologist. And what you see here, and he's looking at a section of a brain of a patient that had an entity that nobody knew. And he published a paper in 1960. And the patients had lung cancer, and all of them had a problem with memory. They couldn't remember, they couldn't form new memories. And they also had depression and anxiety. And at that time, this was thought that this was like a degenerative disease, like it was a dementia in the same type of category, like could be Alzheimer or so. But some of his colleagues that were pathologists saw that in the brain there were a lot of inflammatory infiltrates. So in 1968, that's 8 years after the first paper, he published again, and for the first time, he used the term limbic encephalitis. And because he realized that these patients had an inflammatory response against one area of the brain that's called the limbic system. And the reason that these patients couldn't form memories and had all these symptoms was because they had this inflammatory response. What he didn't know, and I don't know if ever he figured it out, is that actually these patients already at that time, there were colleagues of him in England that have reported in another group of patients that had sensory symptoms, reported an antibody that reacted with the neurons. And what you can see here this is a Guinea pig brain, and is a stain. What you see that is, what you see here in white, these cells, these are the antibodies of the patients reacting with this. It turned out that it took many years, and it was 2 blocks from here when my mentor figured it out what these patients had. And he rediscovered these antibodies, and he made the link with this type of encephalitis. And this was Jerry Posner, and this is my mentor. He used to be the chair of neurology at the Sloan Kettering. And this is my dear friend, Francesc Graus. We work together now in Barcelona, but Francesc was with Jerry Posner when they figured it out that these antibodies that you see here now in color, these antibodies reacted with brain, and what these patients had what was called a paraneoplastic syndrome. Paraneoplastic syndrome linked to small cell lung cancer, and these patients have a sort of a number of symptoms. And it took a few years later, a few years more, to figure it out that these antibodies, in fact, were not the ones that caused the disease, but were the T cells. So the antibodies were like markers, and the T cells were the ones that were damaging the brain. This is a cartoon that Cesc and I recently published in the New England, showing that actually are the T cells that are eliminating neurons. And this is not a cartoon. This is actually the brain of a patient, a biopsy. And what you see here is a neuron and is indented by T cells that are damaging these neurons. So all of this, it was possible by Jerry Posner and by my friend Cesc Graus. When Cesc left back to Barcelona, then is when I came here for 1 year to work with Jerry, and it turns out that I spent 25 years. So it's a little bit miscalculation from my part, but so this is how it went. So these rare diseases, led us a number of years later to identify a new category of disease, because this is not only a single disease, the one that I was showing you. This is a whole group of diseases in that antibodies target intracellular proteins, but the bad guys are the T cells, and these are tremendously difficult to treat, these diseases, and most of the patients, they don't do well. However, there is another group of diseases in that they are much more frequent than these ones, and despite that they are much more frequent, they have been more difficult to characterize because these antibodies here, these antibodies attack something that is on the cell surface. The antibodies here, they cannot attack something that is inside the cell, but in here the antibodies attack something like the NMDAR receptor and some other receptors that are on the cell surface. So the antibodies can reach this and can cause some changes and can cause directly the symptoms. And this is shown here when you compare a live neuron exposed to these previous antibodies, these historical antibodies. You don't see any reactivity. This is just to show that there is a neuron here. You don't see any reactivity because the cell is live and the antibodies cannot penetrate. But in here, and this is actually the patient that had antibodies against the NMDAR receptor, this is a live neuron in a Petri dish, and what you see is that the antibodies right away bind, recognize the cell surface, and this could be the AMPA, this could be another receptor, and when these antibodies are able to recognize something that is on the cell surface, they cause changes. This seems to be very simple, but it's a simple concept, but it's very, very important because the T cells are killers. The T cells eliminate neurons. If the neurons are gone, it's very difficult to repopulate this, although, you know, there are some parts of the brain that seems that you have neurogenesis, but in many parts not. In here, the antibodies cause changes, not killing the neuron, but changes, functional changes. So if you eliminate the antibodies here, the patients can recover. And this is why these patients respond so well to rituximab, or sometimes not so well, but compared with these ones here, they do much, much better. Now, this is a cartoon to characterize two groups, not two diseases, two groups and two large groups of diseases. And I'm going to talk today mainly about the NMDAR receptor because I don't have time for more. I'm going to go back and forth, and I'm going to give you some suggestions on what I'm talking about, if it's the NMDAR receptor or something else. But in here, I'm going to concentrate in this new group of diseases that basically started being discovered around 2005. Okay, so this is like basically almost 30 years after the work of Cesc Graus and Jerry Posner at Sloan Kettering, and my own work at the Sloan Kettering when I started here. So since 2007, there are 15 diseases, and all of these diseases pertain to this category of antibodies recognizing proteins that are on the cell surface, like the NMDAR receptor, like the AMPA receptor, the GABA receptor. Some are receptors that are excitatory, others are receptors that are inhibitory, and depending on the antibodies, the type of syndrome or the type of disease or manifestations or symptoms are different. And also depending on the type of antibody, you can find sometimes that patients may have a tumor or may not have a tumor. In some diseases, you basically almost never have a tumor. In other diseases, it's much more frequent. And in here, some of the tumors can be benign. So this is also very different from this group of diseases in that the tumors are almost always cancer and highly malignant. So I'm going to talk a little bit about the NMDAR receptor encephalitis because it has led the field. So after a lot of months and years working with NMDAR, particularly at the beginning on the NMDAR receptor encephalitis was a totally unknown territory. We have learned a lot of how do shortcuts in some of the investigations when we identify a new antibody. We know right away what we have to do to characterize better the disease. So I'm going to talk the NMDAR receptor for several reasons. Is the most frequent of all of these, and at the same time is the best studied. And this is how these antibodies are seen. This is the spinal fluid of a patient that has antibodies reacted. This is a section of rat brain. The proteins of rat or the proteins of mouse in the brain are not so different from the proteins of the humans. We are very close to the rats in this sense. So the proteins are very similar in sequence, okay? So it's much easier to use tissue, very fresh tissue of rat brain, first of all, because you can sort of euthanize, you can kill a rat, eliminate, take out the brain, very fresh, and this is very, very much needed for this type of antibodies. And if you find this, if you want to use, for example, human tissue from biopsies or from autopsies, it's much, much more difficult because the tissue has been processed, is fixed, is not exactly, it does not have the quality of this tissue. So what you see here is an area of the brain that's called the hippocampus. And what you see, all these green are the antibodies, the NMDAR receptor antibodies binding to many areas of the brain, mainly in the hippocampus. So now this is tissue that is, of course, is dead tissue that has been processed very rapidly. And so you put the CSF or you put the serum and the antibodies bound, and then there is a technology to show how this binding is reflected with this green fluorescence. This is with live neurons that I showed you before, and you see the reactivity. And these are cells that have been manipulated to express. This is a cell line that you can buy, and you can, this is a very clean cell line, it's a cell line of kidney cells, and they are very clean. They don't express receptors on the surface, but with technology, you can make these cells to express whatever you want. NMDAR receptor, AMPA receptor. So in this case, these cells express NMDAR receptor, and you see how the antibodies of the patients bind to here in green. This is a receptor, a cartoon of the NMDAR receptor, usually has 4 subunits. I'm showing here one NR1, another one that's called NR2 or GLUN2, but there are 2 more identical, so it's 4 subunits per receptor, and the antibodies bind to the GLUN1. And this is very important because there is a lot of literature of antibodies against the NMDAR receptor, but they have to be exactly like this, the way that are shown here to characterize the disease as anti-NMDAR receptor encephalitis. Because many other antibodies against other areas, other subunits, you don't know what they mean. Sometimes even they don't have any related disease. So this is very important to keep in mind. So my colleague Martin Titular showed you this morning, and this is like if I had to show in a cartoon a very complex disease in a very single type of picture. And this is not easy for this disease. And this was designed by Matt Kaiser, who is a psychiatrist at Penn. And he designed this, and I thought it was a great summary. So many of these patients have like a viral-like syndrome. They develop headache, they don't feel well, a little bit of fever, nothing to worry very much, but sometimes after this, they develop a lot of psychiatric manifestations. They become psychotic, hallucinations, delusions, and very bizarre behavior, a lot of insomnia, they don't sleep, very agitated, sometimes very aggressive. Many times these patients are misdiagnosed like with a psychiatric disorder, and they can even be admitted to psychiatric centers. They can even go to a lot of psychiatric medications, which is not good because they don't tolerate very well these medications. And this is good, at least, that many of them develop other symptoms, and then the disease reveals itself, showing other symptoms like seizures, abnormal movements. And then these patients usually are in the ICU, and they are here in in the red box, they are in the ICU, and then they start recovering if they are properly treated, and this can take a long time. And then here, the patients are again impulsive. They don't have any more seizures or abnormal movements, but they have a lot of impulsivity, a lot of problems concentrating with memory and so on. So there is a lot of literature to try to define here a specific group of psychiatric symptoms that tells the psychiatrist that this is an NMDAR receptor encephalitis, a specific phenotype or psychiatric phenotype. And there is a lot of reviews recently in the literature trying to tell this. Well, it doesn't work. And they can imitate everything. So recently, we came up with this mnemonic term to memorize: search for NMDAR receptor, search for NMDAR receptor. This is not published yet. I hope this will be accepted for publication, but you have to suspect this in the initial stage of the disease. If a patient comes with, usually a young patient, most of them are young patients, with a prominent sleep dysfunction. This means insomnia, not sleeping for days sometimes. This excitement, this inhibition, manic, depressive behavior, agitation, rapid onset. It does not present in many months, it's rapid. And usually very young individuals, children, young adults, with usually no previous history of psychiatric problems. And they can have fluctuating symptoms, catatonia. They have negative and positive symptoms of what's called schizophrenia, but they are not schizophrenic, but they have these negative and positive symptoms. Memory deficits, decrease of verbal output, many of them, they are not able even to talk. They don't tolerate very well the antipsychotic medication. And then you have to rule out some complications that's called neuroleptic malignant syndrome. This disease can mimic this type of syndrome, and it helps very much the determination of antibodies. So this was put together to sort of like an alert. If you go to all these mnemonic search for NMDAR receptor, this may help to recognize the disease, but it's very difficult. This is a patient from Canada, actually, and I never met the patient, but I received an email thanking me for having worked on this disease. And the wife find the patient one day at home doing all these calculations and the stickers all over. And she asked him what you're doing, and he was saying, I'm designing a flying car using nitrogen gas to float against CO2. And this was the clarification, as you can see here, with the car and the car taking off. So this was the presentation of the disease with this psychotic break. And these patients usually go further, and sometimes they go, this is another patient, but this is when they are down to the ICU, and they can be like this for sometimes weeks. In the past were many months before the disease was known. And they don't recognize family members, they don't recognize anyone, they cannot communicate, they need to be ventilated, and they need to have feeding tube. They don't respond to anything. They seem to resist the eye opening, they don't respond to anything. She presented the same way, with insomnia, psychiatric symptoms, before she developed this episode. And this is the patient several months later, recovering. She has lost lots of weight, and she's recovering here, as you can see, with this robotic type of gait. And this is the same patient months later, fully recovered, right? It's very difficult to tell that it's the same patient, but it's the same one fully recovered. And you don't see that. So you don't see that ever in these paraneoplastic syndromes, the ones that develop with cancer and are mediated by T cells. You don't see that. You just see this with the cell surface antibodies. This is another girl. This is from India. And this girl, this shows you the abnormal movements. Look how bizarre these abnormal movements are. And this is quite exceptional, because the doctor sent me this and was asking for help for the diagnosis. The patient had an NMDAR receptor encephalitis, And I thought, oh my God, this patient is going to recover for many months. And he mentioned, no, just in 1 month, he recovered quite well. Yeah, so it's hard to predict. Of course, she was treated with immunotherapy. She didn't have any tumor. She didn't have any teratoma, but it's hard to predict. And so this is a study that we did with Martin when he was with us in Barcelona. And this is a very large study of 577 patients, and it tells you the distribution of age and sex and the presence of tumor in these patients. And in here, what you can see is that most of the patients are younger than 50. Of course, there are exceptions. All the pinks and reds are women or female patients, girls. If they are pink, they don't have any tumor. If they are red, they have an ovarian teratoma that contains NMDAR receptors. And the blues, the light blues are boys and young men. And the very dark blues are men with tumors. So this gives you an idea of the distribution of age, sex, and tumors or not. What's the bottom line here? Is a disease of young people. The median age of here was 21 years. Is a disease that predominates in women, particularly in teenagers and young women is basically 75% or so are women. The younger the patients, and these are basically almost less than 5 years old, the younger the patients, the distribution equals more or less. There is not such a big difference between men, between boys and girls. And also the younger the patients, the less likely that there is a tumor behind that. So if the patient is very young, probably you don't need to go a lot looking for a tumor. It's good to look at for, but you don't to exhaust the patient and the family looking for tumors, particularly in this disease. And it's a disease that you have to suspect clinically because, as very well known, this audience this morning, a lot of arms were raised when somebody said, well, how is the MRI in this disease? In many patients, it's normal, okay? At least at the beginning. And here in this larger study, only 35% was abnormal. And when it's abnormal, it's not really very, very abnormal. It's not also specific. You cannot tell that the patient has an NMDAR receptor encephalitis based on some abnormal findings in the MRI. In this disease, the MRI helps to rule out other things, but doesn't really help very much to make the diagnosis, okay? The spinal fluid is almost always abnormal, but doesn't help you very much. It just tells you that there is an inflammation of the brain, which is very important to know, particularly when the patient presents with a psychotic break that looks like perhaps this could be the first presentation of a schizophrenia. Well, the schizophrenic patients don't have these inflammatory changes. So if you find this, you start putting together the puzzle, and then you can make the diagnosis. The EEG is almost always abnormal, but also is non-specific, right? A lot of diseases can cause this type of EEG that is very abnormal here with this activity that is very slow. It's called delta or theta activity. And in here, this is highly suggestive, but only 30% of the patients have this pattern in the EEG. So is a lot of clinical judgment, okay? The doctor has to know about the disease to make the diagnosis because it's a big mimicker, okay? Can mimic a psychiatric disorder, etc. So you have to be very suspicious of this disease, particularly in young patients that suddenly develops acute psychiatric symptoms. And you have to look carefully at the patient that doesn't have any other mild neurological alterations. That usually is a red flag. And Dr. Titular already presented this. I'm going to go very fast. The outcome of the disease is usually good. About 80% of the patients do quite well with time and with immunotherapy, and if they have tumor, removing the tumor. And already Dr. Titular also mentioned the different types of immunotherapy, so I'm going to skip this. What I want to pay a little bit of attention is in what triggers the disease. This is a common question. Well, you know, in a large number of patients, particularly young women, there is a tumor in the ovaries that that's called teratoma. And the teratoma is a very bizarre tumor. It has different types of layers of cells that when you look at this tumor at the microscope, you can see that there is muscle, you can see that there is hair, you can see that there is teeth, you can see that there is skin, you can see that there is nervous system. The term teratoma means monstrous. Is a tumor that it looks monstrous, and this is the term that they used a couple of centuries ago to define this type of tumor. So it's the presence of nervous system there and cells that express the NMDAR receptors that usually are in the brain, of course, that probably triggers the immunological system. So the immunological system tries to eliminate this tumor, as usually happens, and mounts an immune response against these NMDAR receptors that eventually the cells, not the antibodies, but the cells reach the brain, these cells that have been already activated, and these cells reach the brain, and when they are in the brain, they're still in some way proliferate more there. They are again reactivated in the brain. They progress to plasma cells, and they make tons of antibodies, not only outside the brain, but inside the brain. This probably explains some difficulty in treating these patients because it's much easier to eliminate the antibodies from outside the brain than from inside the brain, particularly because there is a barrier between both sides. And if the barrier, it works very well, the antibodies that are made in the brain by these cells are in a sanctuary, okay? Some of the medications cannot work through the blood-brain barrier. Okay, so you have probably to wait until these cells that make the antibodies disappear, or you kill them with rituximab or cyclophosphamide. Sometimes if you act very early, probably you don't need these medications. There is another trigger that I'm going to talk about this later, that is an encephalitis mediated by a virus that is herpes simplex encephalitis. And this is a very small number of patients with this disease have this trigger. And actually, the disease is not exactly an NMDAR receptor encephalitis. These patients usually have several antibodies, but an inflammation, highly destructive viral infection of the brain can trigger an immune response against the brain, probably because liberates a lot of proteins from the neurons. And again, this was like if it was a tumor, it's not a tumor, but these cells, these proteins released by the neurons that are being destroyed by the virus, in some way, these proteins, among them the NMDAR receptors, initiate an immune response that then attacks the brain. So I'll talk about this a little bit. Now, when we look at the serum of the patients versus the spinal fluid, you always find in the spinal fluid very high levels of antibodies compared with the serum. This is very important, and for many years have been a major problem and a major source of diagnostic errors. Patients with an NMDAR receptor encephalitis have antibodies in CSF, not only in serum. If you find antibodies only in serum, means that there is an error. It means that there is a problem. It means that this patient doesn't have an NMDAR receptor encephalitis, so that probably the antibodies are misinterpreted. It never happens the opposite way. And on top of that is that some patients, they only have antibodies in the spinal fluid, about 14% of patients. So don't waste your time with serum. If you suspect this terrible disease, do a spinal tap and save time. This is the brain of the patient, and these patients used to die, and they don't die anymore. Because now we have treatments and they are diagnosed. But this is the brain of a patient who died. And what you see here is all these cells that are the plasma cells that are making the antibodies. So it's a terrible disease, but it has changed. So what I want to show you now is that these antibodies actually have effects. And the first studies that were done just in a Petri dish. And these, I'm going to show these very complex. There are multiple studies, and I'm going to show you this and a scheme of that. So in a Petri dish, you put neurons that are live neurons of rat brain, And in these neurons, you put the CSF of the patients that have the antibodies. And what you see here, or barely see, but you see a shape of a neuron. It means that these are the antibodies that I showed you before binding to the cell surface of the neuron. If you wait a few days, you put the antibodies, you wait a few days, you realize that this staining is down. This is because the antibodies bind to the receptor, don't kill the neuron, but internalize the receptor, so the neuron gets depopulated of the receptor in the synapse. This is the synapse. This is in the area where one neuron touches to the other neuron. Well, touch not. They go very close together. They don't touch, actually. That was the Nobel Prize of Medicine, Ramon y Cajal. Was a Spanish, probably the only one that we had, but it's considered one of the best neuroscientists ever, but it's okay. We should have more Nobel Prizes. So anyway, he identified that the neurons don't touch each other, okay? They are very close together, and they communicate to each other through signals. And these signals are neurotransmitters and receptors. So there is like a current that goes through the tip of this neuron, and then from there release neurotransmitters. The neurotransmitters bind to the receptor of the next neuron, and this is how they communicate. So these antibodies eliminate the NMDAR receptors from here, and the neurons don't work well. And these neurons and these receptors are very important to form new memories and for many functions in the brain. And this is why these patients develop all these symptoms. These are studies that in a cartoon, but this has been done with microscopy, even with super resolution microscopy. This is a new type of microscopy that allows you to see, actually, to count almost the receptors. This is how precise this microscopy is. And this is also looking at the electrical activity. And what you see here is the neurons that are exposed to these antibodies in blue. They don't have this type of current, that this is the current of the NMDAR receptors. So if there are antibodies, this current does not exist, and just this here. So this is one type of study. These were the first time showing that an antibody can cause neurological problems, perhaps because of this alteration of the receptors. Now, okay, this is convincing, but this is a petri dish. So are these antibodies causing behavioral changes? So for this, you need an animal model. And then what we developed here is an animal in that the antibodies of the patients are injected in the ventricles, in the brain, one area of the brain that is in the middle of the brain, the ventricles, and the antibodies diffuse to the brain. And the animals receive these antibodies for 14 days, and then you can check then with the brain of the animals if these antibodies cause the same alterations, and it caused the same alterations as what you see in a petri dish. But also, before looking at the brain, you have been looking at the behavior of the animals, and these animals have a dramatic decrease of memory, have some other types of behaviors. So this is the first time in that the antibodies showed in an animal model that these antibodies can cause alterations of behavior. Okay, so these antibodies are not only biomarkers, but these antibodies, besides of helping the clinician to make the diagnosis, these antibodies are actually doing something, causing symptoms. And there is a more recent one model in that the animals, they don't receive the antibodies, but the animals are immunized with NMDAR receptors, and they themselves develop the antibodies. In here, we put the brain of the animals, the antibodies from the patients. In here, the animals, they make their own antibodies. And these animals also develop lots of symptoms. They develop like a very acute, very fulminant type of encephalitis with alterations of the receptors and B cells and T cells in the brain. There is still a fourth one in that the animals are infected with herpes encephalitis, with herpes virus, and they develop they were going to develop herpes encephalitis, and actually this is a killer. So what the animals, what is done is that the animals are infected with a virus of herpes, and immediately you start treating the animals against with an antiviral. If not, they die. And what you see is that these animals, when they develop a little bit of inflammation and a little bit of infection by the virus, these animals start developing also antibodies, which is what you see in the humans also. So this has happened in very few years, and you have here in vitro, in vivo, in animals that receive the antibodies, animals that they made their own antibodies, and this is how we know so much about this disease now, and we probably can use these animals to develop some treatment strategies. So this is what I told you before, that the virus, the herpes virus, can trigger also encephalitis, NMDAR receptor encephalitis. And this was an observation that Thais Armangué, she's a pediatrician that worked in my lab. Actually, my lab, 80% of my lab are women. And so they are run by my wife, actually, in the lab more than me. And so Thais is a very talented neuropediatrician, and he made the observation that some children that have herpes encephalitis, a few weeks later, they develop another type of encephalitis, and nobody knew. This was known in the literature, but nobody knew exactly what was the cause of that. And the cause of that is that, again, the virus triggers, after the viral infection, triggers an anti-immune response. So she herself, she's very young, but she's very talented. She put together 19 centers in Spain, and all the patients that were diagnosed with herpes encephalitis for several years, they were followed from day zero of the herpes encephalitis. They were followed, and they would follow progressively, looking for antibodies and looking if these patients developed symptoms. And in this cohort of 51 patients, 3 patients died very early. This is a terrible viral encephalitis. Of these 51 patients, she found that 14 actually developed antibodies in the next few weeks, and all these 14 patients developed a relapsing encephalitis that was no longer viral, but then was autoimmune. So this means that 27% of this type of viral encephalitis develop this complication. And she put together a bunch of referrals that we got internationally. And in here, what we got, it was the samples and information of the patient, not from the day of the viral encephalitis, but from the day that they developed the symptoms of the autoimmune encephalitis. So the study was recently published in Lancet Neurology. This is already published, it's not in press. And a total of 58 patients. And what you see here, this is the 14 patients that developed these antibodies. This is exactly timing this, okay? This is the time of the herpes encephalitis. And this on day 21, all these patients were already developing antibodies. All the positive crosses were antibodies against the NMDAR receptor. And on red is the day in that the patients became symptomatic of the autoimmune encephalitis. And what this study showed is that if the patient is younger than 40 years, they don't respond so well to the treatment. This is what I was telling you. This is not exactly the same as the classical NMDAR receptor encephalitis. These patients develop NMDAR receptor antibodies and other antibodies. But the patients are older than 4 years, they respond quite well to the treatment. So it's worth to identify this complication. So what all this research is leading? Well, we know how to treat these patients with immunotherapy, but what we are understanding more now is the mechanism how the antibodies alter the function of these NMDAR receptors. And by understanding also the NMDAR receptor function in the synapse, we also have identified that there are some strategies to antagonize the effects of the NMDAR receptor. So there is another receptor that's called ephrin B2 receptor that interacts normally with an NMDAR receptor. This is normal. And what we and others have discovered is that when you stimulate the ephrin receptor with this protein here, the ephrin, this antagonizes the effects of the antibodies. So in addition to immunotherapy, perhaps in the future, if you stimulate these other receptors with heparin, perhaps helps to accelerate the improvement of this patient. And this will not be immunotherapy, will be a combination of both. And then there is other types of drugs that perhaps help also to improve the function of the receptors. So the idea in the future is, in addition to immune therapy and wait for a long process of recovery, perhaps some of these strategies help to identify, to improve the patients faster. Now remember that I talk about many other disorders, and this is only one. But for each one, there is an antibody, and in each one, the antibody can cause different types of symptoms or sometimes similar symptoms. Here there are 3 antibodies that can cause a similar type of what's called limbic encephalitis. And in here, the MRI is very helpful. So different from an NMDAR receptor encephalitis, that the MRI is not very helpful. In limbic encephalitis, the MRI is very helpful, gives you a lot of hints in that what the patient is having is an autoimmune encephalitis that attacks the limbic system. And depending on the antibody, some other types of symptoms are a little bit different, and some associations with tumors are different. For example, the limbic encephalitis of patients with this antibody, LGI1, rarely associate with tumors, but the limbic encephalitis of patients with AMPA receptor or GABA B receptor antibodies very frequently associate with tumors. This is one of the few diseases, the GABA A receptor encephalitis, that occurs also in children. Children basically is NMDAR receptor encephalitis, but GABA A is also, and this is a terrible disease in that the patients develop, and here the MRI is also very helpful because they develop these all multifocal alterations, and these patients have tons of seizures, and actually they can actually die having seizures. It's a terrible disease. It has to be diagnosed soon and has to be treated very aggressively. All these antibodies, when you do all these parameters with animal models, all these antibodies have effects on the receptor, and all these antibodies are pathogenic. There are different mechanisms for each one of these antibodies. You can spend a whole talk, but this is how things are leading now to understand. These implications for other diseases, well, there are implications. For example, in Hashimoto. Hashimoto is an entity that is not very well defined. Hashimoto it's going to be redefined. And with these diseases, we are seeing that the incidence of Hashimoto is going down. Why? Because many of patients with Hashimoto in the past did not have Hashimoto, that have some of these diseases, okay? So we have done a study recently on Hashimoto patients, and we identified 24 patients. This was a very selective criteria for Hashimoto. And of these 24 patients, there were groups in that have different types of symptoms, and only some of them respond to steroids. So all the whole story and criteria of Hashimoto have to be redefined. What's more difficult is that the TPO antibodies, you can find these TPO antibodies in 13% of the population. 13% of people here have these antibodies. So if you develop any symptoms and they look for your antibodies, they would tell you that you have Hashimoto, and you don't have Hashimoto. So the TPO antibodies are not very specific. So the conclusions of this study that we're conducting is actually that Hashimoto needs to be redefined, and the shaping of the autoimmune encephalitis is forcing to redefine this, which is good. It's good to characterize the disease. And then I have some slides on the effects also of all this research in psychiatry. The bottom line is that nowadays there is a big move in psychiatry to identify antibodies, and this is becoming a little bit complicated, and probably my colleague Sander Marx is going to talk a little bit about this. But the antibodies have to be very well characterized before attributing psychiatric disease to an autoimmune mechanism. And a lot of these studies are not so well characterized, and I hope that in the future this is going to improve. Despite this, the bottom line of many of these studies on psychiatry is that there is a lot of studies on prevalence to find out who has antibodies, who doesn't have antibodies, but there is a very limited evidence that some of these antibodies are the cause of the pure psychiatric manifestations. So perhaps in the future, what we have to do is psychiatry is a little bit what we have done in neurology, and look carefully at the patients, look for antibodies, try to characterize against what, and try to develop animal models for the psychiatric disorders. But anyway, this is just giving the story very condensed in a few slides. And this is my summary slide of what I talked today. Is that the NMDAR receptor encephalitis and other autoimmune encephalitis are mediated by antibodies. These antibodies cause alterations, as I show you, structural and functional alterations and symptoms, neurologic symptoms, psychiatric symptoms, most of the time together. Understanding the mechanisms may help to develop better treatments. The exact cause of Hashimoto, and this is something that interests me a lot right now. The exact cause of Hashimoto is unknown. There are no antibodies against neurons in Hashimoto, that's for sure. We have looked this carefully. The TPO antibodies can be very misleading. They are not very specific, and there is a pressing need to redefine the disease. And there is no clear evidence that the autoantibodies can cause a primary psychiatric disease, like schizophrenia or bipolar disorder. This needs a lot of research. And this is the whole team in neurology. I told you that most of them are women, as you can see here. It's not, I didn't figure it, I didn't make this up. So this is my colleague, Cesc Graus, is a little bit older than the first now. I'm older also. And this is the whole team, and with all these collaborators. Martin is here, and I have collaborators in Europe and in the US. And thank you very much.